Hi, everyone. Good afternoon, Eastern Time as we cross the noon hour. Thank you so much for attending our second live session to follow up on the video series, How Collaborative Care Enhances Your Practice and Increases Child Mental Health Access. So as folks are getting logged in, we just want to welcome you to our session today and also give you just a few logistical instructions as we get started. As you come into the meeting, you'll be muted with cameras off, and that way folks will be able to see our panelists for the session today and interact with panelists directly. Any technological questions that you have for ACAP staff, if you're running into tech issues, please enter those into the chat. As well, we would love it if you could introduce yourself to the group in the chat. Please give us your name, where you're from, and your connection to collaborative care, some of your why for joining us today. And then questions that the panelists will actually address in the session, those should be entered into the Q&A. So up at if you go and look in your screen here, there is a chat section for those tech questions and introductions, and then here beside it, the Q&A for questions that you would like panelists to answer. And again, our session today is how collaborative care enhances your practice and increases child mental health access. Hopefully, some of you have been able to view our virtual sessions on the ACAP website that's available for free to all ACAP members. We are mindful that some of you may have seen all of the series and some of you may have seen portions of the series, and some of you may not have gotten to it yet, but we very much encourage you to go to the ACAP website and find these 6 virtual sessions. And we began with 6 sessions that are essentially building blocks for getting started and being able to continue sustainable work in collaborative care models. These are our learning objectives for the series. So at the conclusion of this activity, including all of the video sessions and these live Q&A sessions, we want for participants to be able to discuss collaborative care models and how you can enhance your practice by incorporating this. And in addition, how incorporating collaborative care models improves access to critical mental health treatment for children and adolescents. We would like for folks to be capable of implementing one or more collaborative models using transformative best practices by enhancing your partnership with primary care clinicians. We'd like people to be able to develop sustainable funding for collaborative care in order for these models to continue. And also, you should be able to demonstrate how collaborative care can propel leadership and advocacy efforts by child and adolescent psychiatrists. And without further ado, we'd love for folks on the panel to be able to introduce themselves today. So in turn, you'll hear from each of our panelists that are participating in the session and able to take all of your questions. Again, please do bring those questions into the Q&A while we are introducing ourselves. My name is Susie Nelson, and I serve as the moderator for this virtual series. And we have worked as a team in order to put together a great educational opportunity for all ACAP members to become more involved in collaborative care. My passion in collaborative care comes out of work that I have done in this space, and I currently serve as the Director of Integrated Behavioral Health at Dayton Children's Hospital in Dayton, Ohio. And I'll turn it over to Dr. Borer.
Hello, everyone. My name's Mark Borer. I'm a child and adolescent psychiatrist in Dover, Delaware. I'm in a small private practice, but have spent time developing a collaborative care model with a large pediatric practice. And I'm also working on collaborative care program for a school. So it's been a lot of fun, and I hope you'll enjoy this presentation. Thanks.
Erin Chidzig Pryor. And Erin may be joining us here in just a second. I'll turn it over to Dr. Jeffrey.
Hi, everyone. So great to be here. My name is Jessica Jeffrey. I am the Associate Vice Chair of Clinical Affairs at UCLA, and I'm also our lead child psychiatrist for the Behavioral Health Associates integrated care program at UCLA. Additionally, I run a DMH program, a Department of Mental Health program, focused on collaborative care to some of our outlying areas in Los Angeles County. So great to be here and eager to contribute today.
Dr. Gurindo.
Hi, everybody. Tristan Gurindo. I'm a child psychiatrist in Washington, D.C. I am also the former chief medical officer for Optum Behavioral Care. While I worked at Optum, I helped lead an enterprise work group across United Health Group, looking at how we could expand access to collaborative care from the payer side. Currently, I'm working in a consulting company looking at care transformation and helping practices implement and expand their collaborative care programs.
Dr. Hopkins.
Hi, everybody. Good morning, for me at least, on the West Coast. My name is Melissa Hopkins, and I'm a child and adolescent psychiatrist in Sacramento, California at UC Davis. And I started and I'm the director for our Pediatric Integrated Behavioral Health Services here at UC Davis. And I'm really excited to be here today to talk to you all. Thank you.
Dr. Krishna.
Hi everyone, Rajiv Krishna, child and adolescent psychiatrist in Maryland, currently working as chief of medical staff at Sheppard Pratt. I been working with the HCAE committee for quite some time around measurement-based care, which is really a critical part of the infrastructure for collaborative care, which is part of what has me here.
And Dr. Schlesinger.
Hi, I'm Abby Schlesinger. I forget how to turn on my audio after all these years. I am also a child and adolescent psychiatrist. I've been practicing integrated care for over 20 years. I'm the clinical chief of child and adolescent psychiatry and integrated care for Children's Hospital Pittsburgh and Western Psychiatric in Pittsburgh, and have had the opportunity to work in a wide variety of integrated care settings, from small practices in rural areas to a large integrated network in an academic center.
All right, great. Thank you so much to all of our panelists for being here. I don't know if Erin had, I'm not able to see the screen at the moment to see who is in here, if Erin had logged in to introduce yourself. Seeing as we are at 10 minutes into the hour, our final slide before we get started is just a reminder. At this point, probably most of you are in the session. Just a reminder that if you run into any tech issues, including in the middle of our session today, please do reach out to the ACAP staff, who will be monitoring the chat function here in this portion of your screen. And if you would introduce yourself also in that same portion, give us your name, your location, and your connection to collaborative care. And then beside the chat is we're doing this virtual session just a little bit differently. We're going to make use of a function called Q&A in this webinar. So if you go to the Q&A, please enter your questions for the panelists there. And I will go ahead and stop sharing so that I would be able to come in and see the Q&A. So I see a lot of introductions in the chat. So thank you so much for joining us and being a part of our discussion today. And actually, I do see a message here to us on the panel, and just want to reassure folks that if you had not yet had a chance to watch our 6-session virtual series, that is totally okay. Please stay with us, participate in our discussion, and be a part of this community. And hopefully you'll have an opportunity to watch those at some point, and you can kind of bring that together with what we've discussed today. So this is really built for people at every level, whether you've watched all 6 of the videos or any of them in portion, or even if you haven't had a chance to do that yet. So we definitely welcome everyone to the discussion. I will open up and see where we are with our Q&A. And actually, as we get started here, all right. So one of the questions and also for those of you who had registered and had entered some questions in at the time of registration, I see this one about training, and there's a couple of different connections to training, both for psychiatrists and also for pediatric primary care residency training. And so I wonder actually if either Abby or Melissa had some comments about the training environment, both training pediatricians and pediatric primary care clinicians, and also training in the psychiatry space.
Melissa, do you want me to take this and then I'll let you sweep up? It's a big question there. I think probably a lot of us in psychiatry have experienced the wide variety of mental health skill set amongst pediatricians and family practice doctors and APPs. There are lots of opportunities to train practicing clinicians to get them up to speed with substance use screening, other types of screening, and the skills they need to do the basics of behavioral health and primary care. I think that there's been increasing interest in doing this over the last 10 years, with a real increase since the pandemic, which probably a lot of you have already seen. I know one of the questions we had in advance was like, how do you get started in integrated care? And in fact, many of us have stories about getting started by connecting with a pediatrician or a family practice doctor who maybe saw some of our patients or had some questions and going to present to them on things they want to hear about. So I think there's lots of ways to sort of spontaneously connect with physicians and APPs that are doing primary care that can get your toe integrated in care if you're not in a large system. That being said, I think it's also important to note that the rules, sort of the ACGME rules, for those that are close enough to training to remember that, what ACGME stands for, the rules for what pediatricians need to learn and how they learn it have actually changed and are in the process of being implemented, that pediatricians will be coming out with more behavioral health training than we've probably ever seen. It's going to take years to really get to where their goals are. But if you are someone that is training and doing education, you should be aware that the rules are changing. There's a whole bunch more I can say, but Melissa, anything you'd like to add?
Yeah, thanks, Abby. I would say just a couple of items. So on the pediatric trainee side, I've been working with our peds residents at UC Davis for a while, and I think one thing that's been really helpful is to try to stick to the data. And so, whether you're working with trainees or practicing pediatricians and other primary care providers, I do think that getting the lay of the land when you're starting to work with them and understanding kind of where their baseline is, so that you can really tailor your engagement with them to where they are, has been really helpful. And so, through a combination of kind of that needs assessment and understanding kind of where they are, what they're wanting on the education side, and then a variety of kind of high yield topics that kind of I've approached in a more structured way. So kind of having more didactic sessions on really high yield topics. And then leaning into more case-based teaching. And so every opportunity to work with a pediatric provider is an opportunity to teach them. And so, all of our consultations and engagements that we have with our trainees and our pediatricians, we're really integrating that teaching into each case to sort of reinforce the concepts that we're also teaching in a more structured way. And so kind of pairing that together has been pretty effective. And then I would also just say on the child psychiatry side of things, there's a pretty wide range of how our residents and fellows are getting exposed to integrated and collaborative care settings and getting taught those models. I think more and more they are, which is amazing. And I think exposure is just the biggest piece. One thing that is really important is kind of focusing on the relationships, which I'm sure we'll talk about a lot today, but making sure that we're really teaching skills to collaborate and coordinate and have like more bi-directional approaches to care with our patients. And, also just again, exposure. So having people work together, more opportunities for that has been really effective.
Melissa, can I add about the child psychiatry trainees? I think it's really important that we teach our child psychiatry trainees, and we even think for ourselves as attendings in the field, that we really meet the pediatricians and the primary care doctors where they're at, and don't assume that because we're interested in something, they'll be interested in it. So that's part of what we do for our trainees at Western Psych, is we actually have them practice doing a presentation in 20 minutes in a way that a pediatrician might want to hear it. They can choose family practice if they want to too, because they may have different needs. But thinking that just because we think something is interesting as child psychiatry, that that's what pediatricians need to learn, that is the first mistake that you can avoid. So.
Yeah, thanks, Abby and Melissa. I will echo that the involvement ultimately starts with that, pediatric primary care clinician or family medicine primary care clinician often reaching out, whether that's in a training setting or not in a training setting. Usually their initial reach out of, hey, you're a psychiatrist. And sometimes, we'll get that, I found a unicorn and they really are eager to be able to consult with us and talk with us about cases and get that assistance and that help. And so that is the beginning of that working relationship and that collegiality that you'll build on for being able to get involved in integrated and collaborative models. And actually, just to build on that concept even further, I want to ask Mark to address a question that came in with those pre-submitted questions about getting started in collaborative care when you're not in an academic setting.
Well, thanks, Susie. And it's really been a fun process. It's a nice way to take a little part of your practice if you're a private practitioner or if you're consulting with various programs, and to use it to increase access to care while you're involved with other people. And it isn't just the pediatrician you're involved with often, it's the primary care manager. And I'm sorry Erin hasn't been able to be on, because she's the one that we work with at Delaware Pediatrics, and she's had a lot of national training, which has really helped. But the thing I found is I had worked with our child psychiatry access program after meeting pediatricians anyway and knowing some of them. And if you have access to your child psychiatry access program, you'll start to get to know some of the pediatricians that call in regularly. And those are the ones, if they're calling regularly, that are really already primed for collaborative care model, because in the collaborative care model, you're basically reviewing a list or a group of child patients and families, often on a weekly basis with the care manager. You're following along some parameters, as well as some screening tools, and you get to actually see these kids get better. So it's a matter of reaching out. I had originally talked to a pediatric conference I was presenting on collaborative care, and one of the pediatricians came up afterward and said, could you come do something with our practice? And I did, and that's the big practice I'm working with now. So I think those are just a couple lead-ins.
And great. And actually, Erin was able to join us. Thanks so much for being here with us today. And any follow-up on what Mark is saying here about getting started in the community?
Yes, absolutely. My apologies for being late. I was with patients. So I think, starting with a small subset was really a helpful way of kind of initiating collaborative care for our practice. So initially we were kind of managing kids who had like the most level of complexity that, maybe even choosing patients who are coming into care, graduating from an IOP or from an inpatient stay, and starting them on a registry and following and tracking them. And I think from our practice standpoint, it was never really a question of like, do we want to do collaborative care, integrative care? Do we want the support of working with a child psychiatrist and having Mark support us? It was more of a, how do we make this work? Like the workflow, the boots on the ground work of like, how can I give better care, all while understanding that my 20-minute well visit is not going to be extended to a 35-minute visit, and taking some of the burden away from the provider not always having to do the follow-up or being reliant on the family or the counselor, reconnecting and calling back. Getting really good workflow relationships going really, I think, has made the biggest difference for getting the buy-in from the rest of the providers in the practice, and really seeing the outcomes, allowing us to expand the model beyond just the most difficult kids to new kids starting on medication for ADHD who maybe need closer follow-up with prescriptions and med compliance and getting copies of testing or requesting testing or IEPs or 504s, has streamlined so much within the practice that it just has been altered so much of what we do for mental health. It's been so positive. And that has allowed us from a billing standpoint to really get good workflows in place and understanding around consent. And it just has grown and grown and grown. And we're the only practice currently in the state of Delaware doing it. We were bought out by a larger physician-owned group who has several practices in the state of Delaware joining. And now we're having discussions about how we can teach them to do collaborative care in their practices with the support of their existing teams and adding in the psychiatry piece of that.
Susie, can I add something to that? I think contextually we're like a super interesting point in the evolution of collaborative care. We're past the point where we're looking for studies that say, is this effective? Like, how many studies do we need? We've like over 100 randomized controlled trials. Like we're swimming in data that says the model works. But we're at this really interesting point where when you go and you talk to a practice and you say, we'd like to bring the collaborative care model, they look at you with a little bit of skepticism because they're like, if it's so great, if sliced bread is so great, why are we just now learning about it, right? And so, there's kind of this belief that like, it must be too hard. That's why we're not doing it. Or payers must not be paying the codes. That's why we're not doing it. Or it's way too complicated and that's why we're not doing it. And what it really takes, when I think Mark and Aaron just alluded to, is relationships. It's about having that relationship with the pediatrician and say, hey, look, we know what we're doing. The model works. Payers will pay. The staffing is, we can sort out the right amount of FTEs to make this thing financially fly, and to have the relationship to say, let's pilot it, let's get started. And I think as Aaron just talked about, once you're successful in one practice, the powers that be start looking around and say, hey, what other practices can we start taking this to? Like this has worked out so great. How do we now spread this across our entire system? So it's a really great time to be in the collaborative care space, because we're tipping from that, like, is it a real thing? We're moving out of that mode and much more into the like, okay, how do we build this from the bottom up? And ultimately, outside of like ACOs or other sort of accountable organizations, like it's going to, in the community, it's going to have to be built from the bottom up. And that's, I think, the work that we're starting to see now.
Caitlin put a great question in the Q&A that's very much related to this, and wondering a little bit of that. Tristan, your comments remind me about the tipping point concept, and and when we will sort of transition to the place where this is very widespread, because we understand that it works and people are really implementing it, and definitely by like building on that relationship, that's how we reach that. And I wonder, as we do that in a practical sense, how would you introduce the next step from, we're doing some regular consults and curbsides, like Caitlin is asking, to building that true collaborative model? What do folks see as being that next step, point in the conversation with the pediatrician with whom you have developed that relationship?
I'm happy to start and let other people chime in. I think what it takes is truly a champion at the local level, at the clinic level, both on the medical side and on the behavioral health side, who are willing to push this forward. I mean, the biggest barrier to implementing collaborative care, and we've been doing this work, the first big rollout of collaborative care nationally was in 2015 with a grant from CMS that was trying to like increase adoption. So 10 years later, we're still pushing the same boulder up the same hill. And it's really about practice change. It's about having a champion at the local level who's willing to sit down with the behavioral partner and say, let's redo the workflows. Let's educate about the model. Let's go talk to the billing people. Let's build the pro forma to convince the finance people that this will work. But it starts with the relationship, and then it's got to evolve into champions. We're the experts in the child psychiatry realm on the behavioral piece of it. They're the experts on their practice. And ultimately, like, they've got to be able to sell it internally, but we can be really strong partners and advocates in that. And I would say Caitlin's comment, she also mentions that she works in an FQHC. It's trickier, right? Because like they bill a little bit differently, and traditionally they've kind of had to use a G code that's like for a care coordination code. So that's kind of been a structurable barrier. But a lot of those coding changes are occurring as well, which are going to open up the collaborative care. So I think, Caitlin, you're in a good spot for finding a champion partner to help drive this forward.
I'll make a comment about scaling up, as I saw that in your question, Caitlin. And I do think actually that's a great way to think about how to start these models, especially for the collaborative care model. And you can start off with a subset or one part of the population that you're targeting, like depression, for example, and then from there expand into other diagnoses, anxiety, behavioral issues, and that is one way that you can think about scaling up. I'm sure there are others too, but actually doing that allows you to kind of not get ahead of yourself and actually build in a way that is meaningful and sustainable. And so oftentimes, especially when you're starting a new model or a new program, there are a lot of challenges along the way. And so that allows you to troubleshoot and figure out kind of where the pain points are. And it also allows you to show your efficacy. And, one great thing about collaborative care model, of course, is that it's a measurement-based approach. And so in theory, you have data that you can really show this is working and these kids are getting better and get more buy-in from your stakeholders and, leveraging your mental health, your health champion to be able to get more buy-in from your partners. And from there, you can grow in a meaningful way that isn't, again, getting ahead of yourself so that you're, not able to kind of meet, this is the need that we have here. And so if you kind of grow too fast, then you may not fill all of your spots, and then you might make your partners unhappy. So I think that's a great way to kind of think about it: is start small and show efficacy, and then build in the areas that, again, are really needed. And so again, I mentioned the needs assessment earlier for thinking about education. You can also do this for thinking about where the areas where you want to start first are. So if your partners are saying, we have a lot of kids with ADHD and they're really struggling with behavioral issues, like that might be the area where you need to start, because that's where the interest is. And so again, getting the lay of the land before you design kind of your approach can really help you do that in a meaningful way.
I would like to add a quick thing too. Thank you, Melissa. What I would add about training also is it reminds me a lot, being out in the field doing this, it reminds me a lot of when you do consultation liaison work, either in training or in the hospital. It's just that many times you may not see the patient directly. And I know for me, I always like to do these very, very thorough evaluations in my office, and I take pride in doing a solid evaluation. And so sometimes it takes a little leap of faith to realize that you can be very good at doing that. And you can also be very good in learning to trust the pediatrician and the behavioral health care manager to give you what you need to be able to have input. And I think that's another just kind of an inner emotional thing that a lot of us have to face to actually do this work. And it works. And you'll still be thorough when you do your own evaluations at your office, and you'll be able to be thorough in a different way with, the collaborative care model.
I totally agree with everyone had. I want to add a little bit to what Melissa said and a little bit to what Mark said. In terms of, and what Tristan said about building, I agree with scaling up, but a skill set you need here when you find your partner, right? When you find that other person who's going to be your partner, is really thinking about where are they in the system? what are they ready to do, and what sort of drivers do they have for the choices they're going to make? So as psychiatrists, we have learned how to think about what people want, right? How to think about how to get there. We have some of these skill sets already. I think a mistake I see, sorry, this is my second mistake comment, but I guess a mistake I see sometimes is that as psychiatrists, we go in there and we talk only about what clinical conditions are we going to deal with, instead of thinking about what's going on in this system. What does the system need? Even if it's 5 doctors, what are they looking for beyond just the clinical piece? What strengths do they have, right? Like, is there a really great front desk person that's going to take this on and answer the phone calls for you? And what sort of areas might they need more support? So I really think you need to have a moment with your collaborator, your pediatric collaborator, on where you both are, and recognize where you're aligned. And there may be places that you're not aligned, and that's okay. But you're working towards the same goal. And then I guess I also really resonate, Mark, with what you said about how it's a different skill set. For those of you who mentioned being on a CPAP program where you have to take phone calls and trust what the pediatrician gave you, I think that is a different skill set altogether, and one that we're starting to train pediatricians for, pediatricians and psychiatrists for, and one that we're going to have to continue to sort of develop across our field. But it's a really rewarding skill to help pediatric providers, people serving pediatric patients, get better at what they're doing. And lifelong friends, frankly, from people that I started training 20 years ago who are already attending. So.
Yeah, this reminds me of a conversation I had recently with a colleague here in Ohio about trying to kind of move the needle a little bit on collaborative care, because we happen to be one of the areas of the country where our collaborative care codes are not fully on, and so we're kind of building this a little bit upstream. And but they talked about conceptually that idea of building on the relationships that we have with pediatric primary care clinicians is the start slow to go fast, that needs assessment process that Melissa talked about, and thinking through some of the practical steps along the way, and that planning that you invest up front pays dividends later in terms of what you're able to do in the model. And so really putting that into it. One of the aspects of how we build the system has been mentioned a couple of times and alluded to in some of the comments. And we had a couple of questions about this as well. And that's measurement-based care. And so I wanted to see if Rajiv or Jessica wanted to comment a little bit about how we use measurement-based care in the collaborative care models.
I can take a first crack at that a little bit. I think it was a little bit off of the question, but I was thinking about this in the context of you and getting started. And one of the challenges with getting started is finding a common language and a common way of communicating. And I think this is one of the key areas in which having a measurement-based care infrastructure, having this, getting to what is the registry? How do you set it up? How do you get sort of these consistent data? And it can be really helpful with that process of kind of bringing everybody together. Pediatricians are already using measures. That's something they're comfortable with. It feels more objective, which I think is a challenge in sort of bridging communication between those areas. And it's something that you can look at really quickly and get a first pass sense of what you're dealing with, which I think going to that, how do we not turn this into a 30, 40-minute visit, becomes really important. And so to that piece of how do you get started in this, I think, and granted, I'm a little biased since this is the area that I've done a lot of work in, but I think having that discussion about what are the common measures and what are the ways that we're going to work together on this through this kind of common language can help with that process as well.
Yeah, I just like to add on to that too, and I absolutely agree with everything you said, Rajiv. So I think, by creating a registry and using, we actually here at UCLA, and I think in many places we use rating skills that are in the public domain because we want them to be readily accessible. And really by creating that common language, again, you're able to speak across specialties And really, I think it will help us as the child psychiatrist to have a better understanding of what the pediatrician is seeing and experiencing if they're able to report those scores, and vice versa. Because the idea, again, is not just assessment, but it's also tracking progress in treatment over time, right? Which is really what the measurement-based care is, and that is the essence of the registry. So again, I just want to reinforce this, that common language, we really understand what each other is talking about. And I think when you look at those rating scales, you look at the detail of those rating scales. So if you take the PHQ-9, for instance, what are we really tracking? Which symptoms are elevated? How are we conceptualizing the etiology of a particular symptom, right? So on a PHQ-9, there can be a notation of difficulty with concentration. That could be depression. We may need to dig deeper. That could be something else. That could be anxiety. That could be ADHD, right? So I think it really gives us, again, what symptoms are we talking about? How do we talk around that? And then how do we track not just the overall score, but even looking at those individual items over time. So absolutely. And that's part of the registry piece. I will just say here at UCLA, we have built in many rating scales that are in the public domain within our EHR. We do track those over time. We do that in the county as well. Very helpful to have a rating scale that is an overall composite rating. So something like a pediatric symptom checklist. Great to have something that focuses on anxiety, something that focuses on mood, like it can be a SCARED or a GAD-7, a PHQ-9 for depression, or moods and feelings questionnaire. But you just really want to also be able to kind of sample different symptom domains. But again, be aware of what the overall score is, but then also look at those individual items and really make sure we're having a thoughtful conversation around those items. I see Mark.
Jessica, yeah, I just wanted to say I have learned more from you, making it easy to go out into the world and use measurements. It's not that hard, and you have made it very understandable. And I just wanted to tell folks that are on here that the Academy offers these presentations on measurement-based care, how to make it easier, how to use it, that it doesn't, like Tristan said earlier about other things, that we don't make it complex, that we make it easy to use in practice. And one other question that had come up in the chat was about making sustainability. And Erin, I'm wondering if you could address that, because, as the care manager at the practice at Delaware Peds, I know that you're the one that set up things with the workflow with the practice for the billing. Could you talk about that a little bit? How we made it where, everybody pays and, and the patients love it?
Yeah. So I think, speaking in that common language, and we use on the registry, the PHQ, the GAD, the SCARED, we have various standardized screener tools that we use, but talking about that scaling up part of it, we've gone steps beyond that now. We measure things like we use a resiliency survey. We're measuring things like missed school days, missed work time for parents, measuring, days with thoughts of self-injury, like acts of self-injury. Because I know everyone has had the experience of being like, the PHQ-9 is still positive, but they have not had, suicidal ideation or cutting, and they've, returned to school and are so much beyond functional, even though the score is still positive. So we've dug deeper into, what measures really count in that sense towards functionality for parents and for kids alike in their academics and their sport and their peer relationships, for parents as well. And how do we get to the point where, we were able to kind of establish this and get reimbursed? So when we first started, it was just seeing my patients on the registry, and we were able to track their outcomes and their billing information, and then to come back to the rest of my work group and say, here's how Erin's patients performed. Here's where the reimbursement looked like. Here's how they paid for rating scales at the visit using the behavioral health assessment codes. Here's how, in between the follow-ups were. Here's the improved compliance with medication compliance, less missed appointments, less no-shows, all of that stuff. And then to be able to say, okay, now we're going to add in 2 other providers who see a large amount of mental health in general. And then to grow that when the practice was seeing the outcomes, and more importantly, I think seeing that we were using our systems in a way where people were working towards the top of their license and using the systems in place to improve communication. So one feature in our EHR has the ability to text that's captured in the EHR, like in the messaging system. And that was a game changer, especially for like communicating to our teams and being able to get an update from a parent, where sometimes it might take 4 or 5 days of playing phone tag with a parent trying to return a call because we want an update on how they're doing since 3 weeks since starting their Prozac. And being able to use the portal, being able to use texting was a huge thing for parents and patients, like loving the way we were able to connect like in real time. At the same time, there were times where I needed to repeat a PHQ and GAD, and that wasn't something that like our front desk staff could do. But if we were like, I'm just waiting for mom to forward me a copy of the IEP, the front desk could send that text message out and I could get it dumped back right directly to me into my portal or into my message box, depending on what the workflow was set up. So, changing that to be like, not everything is necessarily physician level work or provider level work, or even, like a nursing level work or an MA, like what could be done in a different way. And using automated system things as well to be like, could we set reminders to be like, you're supposed to give me an update, or I'm still waiting for Vanderbilt's from your teacher, that we could automate into our system to go out automatically. And I think really looking at like your workflow, what is your EHR capable of, and then what other systems might you have in place to be able to maximize on that. And we were so successful with our outcomes. I believe that for one of our Medicaid MCO plans, at some point they stopped paying the collaborative care codes in the state of Delaware. And we were able to go to the insurance commissioner with our data, because our practice is the only one in the state doing it, with patient and parent testimonials, and to show how effective the program had been with improving outcomes, that they reversed the decision. And now all of the MCO Medicaid plans in the state of Delaware are covering the codes again. That was a huge victory for not just our practice, but for all kids in the state of Delaware, to be able to say like, our information and our outcomes are really leading the charge in getting better mental health care for our kids. And I also think that allows for Mark, for our psychiatrist, to see like those kids who truly need to be seen and managed with psychiatry routinely. And then to be able to step up and down. Like there might be times where we had to refer a patient out, they were stabilized for a period of time. The psychiatrist is like, I want you to go back to your primary care. They could continue to manage your medications at this point. And that gives us the ability to say, okay, like this kid really does need to move up. This kid needs to move down. And we've certainly had kids through the years who have been on and off the registry, depending on what the circumstances may be. And the billing has been, at this point, at this point, all of our plans that we're participating with are covering the codes.
Yeah, that is a huge advocacy for reimbursement, victory there that you all won in Delaware. And I know looking at both some of the pre-submitted questions and then a couple that have come in during the call today, I wonder, Tristan, do you have any kind of tips for us as we approach billing challenges and how we can reach this financially sustainable place with collaborative care models?
Yeah. So, from the payer side, we kind of think about the payer world in 3 separate segments. So we think about commercial insurance, we think about Medicare, and then we think about Medicaid. And on the commercial side, across the industry, almost all the commercial plans that I know of are paying the collaborative care codes and paying a relatively decent rate. Medicare covers collaborative care codes, pays an okay rate. Medicaid is where we still see a lot of heterogeneity. So the COCM codes are in about 35 states. even within those 35 states, though, we have some states that are paying really well on the collaborative care codes and some states that are not paying well at all. And I would encourage all of you to take a look. Milliman just put out a report a couple weeks ago, commissioned by the Meadows Institute, which looked at the adoption of collaborative care kind of at the county level across the nation. And it's pretty easy to see where the good reimbursement rates are and where they're not, because you can see flourishing of the use of COCM in places where there's sustainable reimbursement for COCM. I think there are a couple different ways to making COCM more financially sustainable. I mean, so one is looking at your payer mix. And although practices hate to do this, we have seen some practices that basically only offer collaborative care to individuals in certain lines of business, right? So they're going to say, we're only going to offer it to our patients, our Medicare Advantage patients, if you have a large geriatric population, less pertinent for folks on this call, or we're only going to offer it to our commercial patients, or we're only going to offer it to a subset of our commercial patients. It's not great because pediatricians don't like to have to do different things for different patients. Like they want to be able to say, this is our approach to behavioral health, but it is one way to get started, and it does allow you to kind of balance, some of the financial risk as you think about scaling up. The other way to think about it is from the advocacy side, right? That we do have a voice. We have a strong voice in terms of in the state houses influencing, particularly at the Medicaid level, COCM rates or the adoption of the COCM codes if they have not yet adopted them in that state. And so I would encourage you, as you're all thinking about both ACAB's federal advocacy program, but as we also think about state level advocacy that's happening, this is a great topic. Like going in and fighting for COCM codes, just as Aaron and Mark were describing that it did in Delaware. It resonates with legislators. It's bipartisan. It's about helping kids. I mean, this is not a complicated sell. And in many states, we're just waiting for the states to either fund it adequately or to fund it at all, and particularly in the Medicaid plans. And so I think that's the next big front in terms of like broad scale adoption, the next big barrier that we have to work on.
Great, thank you. That's super helpful. It's definitely an uphill climb for some of us to figure out how we do this in our areas. So and then I saw a question come through, and if you happen to have the Q&A open and also the chat still open on your screen, the Milliman report that was cited, Karen from ACAB put that into the chat there, the link for that. So if you want to follow that, please go to the chat and find that link. We will save all of this information that folks are populating into the chat and into the Q&A so that we can kind of create some references for this for folks later. So thank you. There's a question about structured needs assessments, which actually, I think Melissa, some of the work that just looking just generally at all of the data that we could be, collecting for collaborative care and integrated care models, I think thinking through how we can better structure needs assessments with maybe some common elements, and then maybe other additional things that particular practices may need. And I wondered if you had any thoughts about that, and because I know that's something that I'm really interested in collaborating with other folks in integrated models about, is how can we sort of build a needs assessment model that can be used by many people that are going into this.
Yeah, I'm happy to touch on the needs assessment piece. I know I've already kind of referenced it multiple times, and I'm a big fan generally of getting needs assessments and having baseline data and then kind of coming back around and reassessing. And so, our program has been running for about 6 years now. And so when I started off, we developed a needs assessment of our pediatric and family medicine primary care providers that we're going to be supporting. Our model supports many, many clinics at UC Davis. And so we kind of have a wide range, and we want to get a sense of the variety of baseline provider comfort, skill, needs, desires, wishes, dreams, et cetera. And so we did develop a needs assessment, and then periodically we've sent it out again to kind of measure how we're doing in assessing those goals and see if there's things that are changing over time. And the session, I think number 2 was one that I was involved in, and I do touch a little bit on the needs assessment piece. It's a big component of what we kind of think about in setting up your program and really setting it up for success. I'm happy to share the one that we developed, although I would say, you know, it's not unique or special in any way. I think there's many ways to do a needs assessment, and the idea is that you're really just getting a sense of, you know, what your providers are coming in with in terms of their, you know, desires, what they're looking for from you, and you're building your model. Also kind of their baseline comfort with assessment and management of the common mental health, you know, conditions, and, you know, their skill set as well. And so it gives you an opportunity to kind of get the lay of the land, like I mentioned before. But I'm happy to share kind of the one that we developed here, and I'm sure the others have them too.
Great, thank you. Yeah, so I think it is session number 2 that speaks to needs assessments. Another sort of buzz term that's often used in collaborative care models, measurement-based care. That's session number 4 of the video series. So if you hadn't had a chance to take a look at those, please do. And you can kind of like jump around them and go to the different sessions that you may you know, feel like are kind of more high yield for you. There's a question about declining collaborative care model use when there's primary care turnover among their provider staff, their productivity demands that are ever changing. It feels like I have this growing empathy, you know, living in the world of the primary care clinic and just listening to the chatter, you know, in the charting room together, you know, of the things that are really impacting them. And so I think just, and the question is actually about good examples of websites, handouts, and, you know, how systems and practices can orient and engage. And we just actually have 6 minutes left, and I know folks are probably going to be headed to clinic. And I think that this is probably one of those challenges that would be great for the group to discuss and kind of wrap up on today before we get to our official end. And I feel like I want to ask Abby to start this popcorn.
So I think it is correct that pediatricians and primary care doctors work at a much faster pace than us. That's just the nature of what they do, and I don't see that changing anytime soon. But that fact, and the fact that behavioral health is part of what they do, no matter what you do, makes an argument for a very robust COCOM model. Because when you have a robust COCOM model with a very active care coordinator that's doing a great job, it actually takes time off of their plate. So I think that's an important thing to remember, that a robust model, and we've seen it, will decrease the amount of time that they spend in sort of the common behavioral health scenarios. So, you know, I think, though, you can't just set up a model and just expect it's going to last forever, just like everything else, right? You have to stay attuned to it. I think the things Melissa does, where she, you know, really assesses where things are great. I also think having sort of an oversight group that meets to see where things are, to figures out how to bring in, when people come in new, how to introduce them to the model. Because if people aren't introduced, they'll just keep doing what they did before. So you can't just assume that things are going to sort of organically continue. You have to continue to work on this. I think Tristan sort of referred to that too. You're still climbing all the way through.
I'll just add that, you know, it's incumbent upon the BHCMs, when there is a new provider joining the practice, to go and introduce themselves. That seems obvious, but also introduce them to the model, because there's this assumption that they've joined the practice and the practice has a mature, flourishing COCM program, that this new provider will somehow know how to use it and just refer patients and what the value is. And so, you know, that's one of the things that we've worked a lot on, is how do we make sure that the BHCMs are continuous ambassador of the COCM model to providers, reminding them of the value, and teaching new providers about the value to bring them in, because you do see that attrition as providers leave as primary care providers leave the practice and they're replaced. The referral volume is lower, and a lot of it could be mitigated by just by educating that new primary care provider on what the model is and how to use it.
I'd like to add as well, I think it's such a good question. And Richard, our program is also virtual and asynchronous and large across many different clinics. We support like 14 clinics, and there's a lot of turnover as well, and also trainees who are new every year. And so we've struggled with this same thing. And even if I love the idea of having that continuous ambassador, and definitely if you have people who are on site, especially in some of these clinics, you really see a difference when there's face-to-face time. We have found that despite our efforts to kind of develop written materials and kind of share things through email and that way, and relying on our partners, our mental health champions in each clinic, if we have them, to kind of share kind of what the model is and what we do, that really there is no substitute for face-to-face time. And so what we have started doing is actually doing every 6 months, just meeting with all of the new providers who have started in the past 6 months and doing a face-to-face session where we're welcoming them, actually getting a sense of their background and what their comfort is, a little bit more of that needs assessment piece, but informally, and then telling them about services and how to refer. And that has really helped kind of keep things going for us. And so that's relatively new, but that is something that we're doing, because just sharing written materials has not really been that effective, unfortunately, despite our best efforts to do so.
Yeah, that makes a lot of sense. Erin, you've got a comment, I think.
Yeah, so we also, had a period of time where like we were not getting a lot of referrals coming in. And part of that we learned was that the providers were becoming more comfortable and not feeling like, oh, I'm not sure what to do if Zoloft isn't working. I wasn't, automatically adding Wellbutrin or something. So, moving past that, of just refreshing with providers about it's not always level of complexity that needs the patient referred onto the registry or that COCM can be supportive for. We also have, Dr. Boris still does education like twice a quarter with the whole group over like a lunchtime series around a topic. And we'll sometimes do like some case presentation. I meet every month at our providers meeting. I always have like a COCM kind of update or topic to talk about not just our outcomes, but hey, like think about referring this patient in. I'm constantly kind of on them to be like, you clearly have a lot of patients that would benefit from having this model. It's not like territorial, like I'm not trying to strip them away from you or strip away your decision making or have them see me, but really just enhancing what you're already doing and taking it off their plate. Because I don't think you're going to meet anyone who's like, no, I don't want better outcomes for my patient. Like, yes, of course they support the model, works, and the data is all there, but telling a pediatrician like you have to do this and you're still only going to have 20 minutes, like you need to come to them with a workflow that demonstrates like, I'm not asking you to add more onto your already too short visit in order to accomplish that. And that really is the crux of like how we've been able to get it going and to get buy-in.
Yeah, that's great. And that point of empathy for, what our primary care colleagues are living day to day in clinic is so critical. I love the ambassadorship, that we all agree that we're taking on in this. And it's so interesting how, the basics of what we do as psychiatrists really come into play here. There's so much that is about a relationship that you initiate, that you build positive regard, and that you build on that, and add to that in these relationships with our primary care colleagues and supporting them with any collaborative and integrated model. So a couple of folks are starting to kind of jump off, and if we have any other comments at the end, I'll let folks do that. I am going to share my screen as we wrap up today, and just make sure that I mention a couple of things. A hidden objective in what we are doing with this is that we really want folks to join our community in collaborative and integrated models. So please email Karen Ferguson and with a request to be added to the Collaborative Care listserv, and then she will get you added to that. There's so many great questions, and we wish we could have gotten to all of them. Thank you so much for spending an hour of either your morning or afternoon with us to have this discussion. We'll definitely be sort of continuing to collect questions and scenarios and work on ways to address those, including in the listserv. And then in addition to joining our community on the listserv, which is really what a lot of this has been about, is building that community, we encourage you to come to what will be the final session for the wrap up of this entire series, which is an in-person member services forum at the meeting in Chicago. We recently were informed that it was accepted, and so we will be having a live session, a very interactive session among the group, kind of taking a look at what we've gathered from all of you during these Q&A sessions, sort of as an initial needs assessment on our part for how we can meet your needs better. And so we'll be addressing more of that at the Member Services Forum as well, and then adding some things, more resources, to the website as we continue to work on and build that. So please come see us on Friday morning of the meeting in Chicago for the Member Services Forum. Again, thank you so much for being here with us for this hour. We really appreciate you taking the time to be with us, submitting your questions. And again, please join our listserv. Keep the questions coming our way. Take a gander at that virtual series again, and absolutely reach out to us. And we'll continue to share with each other on ways forward for building more collaborative and integrated care models. Thanks. We'll see everyone later.